Well, welcome everybody. We are thrilled to welcome you back to the Maine Rural Healthcare Education Grand Rounds. I'm very excited to introduce our guest speaker today, Dr. Cheryl Seymour. She has worked for the past 20 years caring for migrant and seasonal farm workers with the Maine Mobile Health Program, with 10 of those years being the medical director. Cheryl is an enthusiastic advocate for structurally competent and anti-racist medical care. Community health workers and farm worker patients across Maine are her favorite teachers. She strives to share their lessons with students, physicians, and policymakers in order to inform a radical reimagination of physician training and healthcare delivery. So we are very excited to have her here. And from there, I will hand it over to Cheryl.
Thank you. Okay. I'm going to share my slides, hopefully. Okay. I'm no longer able to see you all, but are the slides looking good to everyone else?
Looks great. And I'll let you know if anybody raises a hand.
Okay, perfect. Or the chat. Thank you. Okay. So I was hoping to speak to you all a little bit about two different things that have been very intertwined for me professionally. One is the idea of structural competency, and the other is the idea or the field of farm worker health. And before I get started, going to share with you the CME information. And I believe this will also be present at the end, but if you text this 90615 to this phone number here, then you'll be able to get credit for your CME. And these next slides are reminding all of us that we have or that I have and I believe no one else involved in this has any thing to disclose in terms of, I just forgot that word, but I'm receiving no benefit from giving you this talk. So as was described in that bio, I'm a family doctor. I've worked my whole career here in Maine for the last 20 years. And all of that time, in one way or another, have been involved with the Maine Mobile Health Program. And so in addition to teaching at the residency up in Augusta, doing sort of office-based practice and for a time hospital and OB work, I've also been involved in the care of farm workers. And it's through that work that I became acquainted with the idea of structural competency. And it's really changed the way that I think about and do almost everything in my work, whether it's teaching or patient care or sort of administrative quality leadership type things. And so it's near and dear to my heart, and we thought it would be a fun thing to share with all of you. And I guess for just a second, I'm curious, there's 11 people now. I think your hands still work. Are there folks who are already familiar with that concept of structural competency? Just raise your little team's hand. Anybody? One person? Two. Well, Kate, yes, Kate does because she's heard me talk about it. Okay, perfect. So maybe some new ideas. As I said, I can't see you all, but I am happy to be interrupted. So please feel free to interrupt at any point. Oh, and joining us, who knows as much about all of these things as I do, is also Dimitri Blanas, who's the current medical director of the Maine Mobile Health Program. So jump in anytime, Dimitri, if there's things you want to add.
Sure.
So what I wanted to try to do here, though we are going to talk about farm worker health, and I hope that maybe for some of you that'll be new information that just changes your understanding of food and agriculture and labor in our state. But my larger goal is to shift for you in as many ways as we can the way that we think about why people are sick and the causes of health disparities, because at least for me, and I think for many folks, at least in my generation of training, the ideas that are embedded within the concepts of structural competency really weren't part of how we understood illness. And so I'd like to expand that for you. And more specifically, the objectives are, as I said, to expand the way that we think clinically about illness, to touch briefly, because we have 30 minutes for all of this, to the concept of structural competency, especially from an education point of view. I'm assuming many of you are involved in education of healthcare workers in different ways. And then to explore these concepts, try to illustrate them through examples from experiences that I have had in caring for migrant and seasonal farm workers. You're going to see that abbreviation perhaps throughout the slides, MSFW, and that's what that stands for. I also want to share that all the photos in these slides are photos of farm workers from Maine, taken as part of a photo documentary project now, like 20 years ago. So they're all in this presentation with consent. So this statement, no one should work with sick people unless they have a deep analysis of why people are sick in the first place. This comes from a woman named Shirley Strong, who is active in a variety of different ways in California. And she's a member of a working group of folks that's been together for probably 5 or 7 years, originally in California. And they're folks who took this idea of structural competency that was first articulated in the literature, and we'll circle back to that. And as their name implies, as a working group, they've really tried to operationalize these ideas to help people from all different kinds of disciplines, not just even physicians, but social workers and dentists and anyone who works in healthcare at all, to take these ideas and share them as broadly as possible, but in a sort of an organized way. And so this is sort of our basis for moving forward, is why are people sick in the first place, and how can we change that a little bit? And because I'm assuming most of us are clinicians, I'm going to do this in the way that we've been taught to think, which is through a case. And this is a patient and a community health worker of ours. She's 66. She's originally from Haiti. And this is a typical patient for us at the Maine Mobile Health Program. So she comes for a checkup for her blood pressure and diabetes. She will be here in Maine for about 12 weeks. And in previous years, the visits describe her as someone who's non-compliant with her medication and diet. And as part of her initial evaluation, we find that she has an A1C of 13.6 and a blood pressure of 220 over 110. So while we're doing this, in addition to everything else, I'd like you to try to also track what's going on for you internally in your body as you contemplate a patient like this, and how it would feel if you were the clinician, if in fact that is your role in life. So when we think about that patient, I slide right along. Before we get into why she's sick, but start to think about what are all the reasons that have that you would use to explain her illnesses and their severity at this moment. I want to back up, and I'm just going to give you a little bit of context very briefly about migrant and seasonal farm workers in Maine, and also the Maine Mobile Health Program. I'm going to try to do it quickly. So there are multiple types of agricultural harvests in Maine that folks come to the state to participate in. The federal government defines migrant farm workers as folks who move for work, and seasonal farm workers as folks who are employed in agriculture, but not for the full 12 months of the year. And in these pictures, I have highlighted some of the major crops in Maine. Blueberries may be the one that you have heard the most about. And if you don't know much about how wild blueberries come to your table, I would definitely encourage you to look into that further. They're raked by hand, and you can see that in the picture. There's also, as most people know, quite a number of apple orchards, and those apples are all still picked by hand. Up in the county, in Aroostook County, is one of the largest acreage of commercial broccoli farming on the East Coast. And that bottom right picture is folks harvesting broccoli, which is also done by hand with a knife and people. And then there's forestry workers, which I don't have a great picture of on this slide. And then the gentleman in the top left is actually trimming up the top of a tree, but I put that picture there as a placeholder for many, many workers that come between October and December to make wreaths that are sold in a variety of projects, both commercially and as part of a project called Wreaths Across America. So quite a number. And there's also many, many more types of farms, but these are the major the major harvests. And the picture at the bottom left is one of the mobile units that we at the Maine Mobile Health Program provide care off of. We're a federally qualified health center, and our mission is specific to serving the migrant seasonal farm workers across the state of Maine. The data that I have here on the right of this slide is from a few years ago now, and Dimitri could probably update us. But when folks try to estimate the numbers of migrant farm workers in Maine over the years, the last 20 years, there have been 3 or 4 different organizations that have tried to enumerate that as the mathematical way of estimating. And it tends to come out at about an estimate of about 10,000 workers. That being said, we're at the present time serving more like 1,000, 1,500 people. So really a fraction of those workers. The map here, as you're able to see it, sort of shows you where those harvests are taking place. The blue is blueberries. Up, as I said, in the county is broccoli, and apples are more towards the central and the western part of the state. But important, at least for our patients, and this is true across the country, but the vast majority of our patients are below the poverty line and served in a language other than English, best served in a language other than English. Here in Maine, we have a mix of folks who speak Haitian Creole, folks who are from Jamaica, who do speak English, but also speak a particular dialect as well of English. About half our patients are Latinx from a variety of places, but are best served in Spanish. And then we have a smaller proportion of folks who are Native American. For the most part, they're actually from Canada, but come down to participate in the blueberry harvest as part of a long Indigenous tradition. Okay, so that's a very, very, very quick summary of migrant seasonal farm worker healthcare in Maine, but that's a little bit of a background context to this particular patient. And so to link us back to the idea of structural competency, I, as a provider over the years, saw many, many patients like this one. And what we're providing for them, typically through our health center, is really a pretty amazing series of interventions to help increase access and work through sort of some of the barriers to healthcare that you might imagine when you start to think about farm workers. So we work with a team of community health workers. They provide transportation, interpretation, health education, case management for all of our patients. We provide our care, as you saw, on mobile medical units. We usually are in at the housing sites or the work sites of our workers. We work in the evenings or whenever they are coming off of shifts. We provide laboratory studies and, diagnostic radiology type of studies or access to those, as well as access to specialty outpatient care, prescriptions either delivered or available in our clinic. We have an amazing behavioral health program with native speakers of both Spanish and Creole, available either on-site or through telehealth. And we have access to an truly international bridge case management system. So on paper, we have a lot of resources that we're able to bring to this population. And yet, the health disparities that we see in our patients continue to be profound and persistent. And that, to me, as an individual, is both like intensely frustrating, and also just became sort of a source of a place to which I was able to bring some curiosity and look around, and these ideas within structural competency really helped me to make sense of what had previously made no sense to me. And I'd like to say also, there are not many people providing care for farm workers, but all of us have patients that are challenging, that make us feel the way that you might feel when you read that case. And so even though the examples that I'm going to use today are from my experiences working with farm workers, the concepts are absolutely relevant to everyone, no matter who you're providing care for, or even the roles that you have in healthcare. Okay, so that's the backdrop that then leads me back to my patient here. So this is my slightly interactive moment in our very brief time together. But when I teach this idea with the residents, what I have them do is say, okay, well, tell me all the reasons why this patient is sick. What is your differential for a very elevated blood pressure and a very elevated A1C? So if y'all for 1 or 2 minutes can come off mic, or if people want to type in the chat and someone can read the chat to me, tell me some of the reasons why people think this patient is sick. Please.
And I'll be monitoring the chat. If anybody wants to put your comments in, happy to read them out.
Healthy diet may contribute a lot to this.
Diet, is that what you said?
Yeah, that's correct.
Yeah. Okay.
We also have access to dietary education, and we have systemic poverty, access to medications, language barrier.
Okay, perfect. This could go on forever, as we might with learners, and spin it on out, but in the interest of time, I'm going to keep going. And often some of the words in white are things that I hear and that people might bring to the table when they think about why this patient is in the position that she's in. And all of these things are relevant. And I broke them down into categories because these are the categories that most of us have been trained to think about. We've been trained to think about biology and literally the body and what is happening in the body, and or how medicines work in the body, and or sort of the genetic factors that may lead the body to work in a certain way. And we all certainly have had quite a bit of emphasis on behavior and helping our patients modify their behavior, whether that's choices in their diet or their exercise. In this case, this patient doesn't use any substances or smoking, but there's lots of ways in which we focus on our patients' behavior. And then we've also been taught about sort of culture, and I put with culture the sort of idea of social determinants of health. So maybe there's something specific to her background as a woman from Haiti that is about what she eats that makes it more likely that she's sick. She's sort of mobile across the country, and that certainly affects her health in a number of ways. Food insecurity is something that thankfully is getting more attention. Obviously, access to care in general. And then, sometimes folks will add into the mix, different people's health belief systems and how that affects the way they engage with healthcare as we provide it. But what I want to add, oh, okay, yes. And so this would be a list of what we would, I think, traditionally call the social determinants of health. All of these things are relevant to many of our patients and definitely to farm worker patients. But when we use these social determinants to talk about illness and even to talk about health disparities, we're usually using them as characteristics of the individual. So this person is poor, they have a mobile lifestyle, they may fear accessing care for a bunch of very valid reasons, et cetera, et cetera. So we're still thinking about the individual. And what I'd like to do is add to these lenses is a term that comes from Seth Holmes, who's a physician anthropologist that has written about a lot of this. We have these lenses we've been taught, the biopsychosocial model of care, but I'd like to add in the end the lens of structure. And by structure, what I mean are the policies, economic systems, other large institutions that produce and maintain modern social inequities and health disparities, often along the lines of social categories such as race, class, gender, et cetera, et cetera. And for those of you who are visual people, these structural competency working group folks that I mentioned at the beginning created this little schema. So we often are focused in healthcare on these, talking about the social determinants of health, thinking about the individual in front of us. But really, it's the structures that are producing, maintaining the social determinants that lead to the health disparities. And so actually we need to be implicating those structures if we're going to make effective change in the health disparities at a population level, but also for our individual patients. This is another schematic that some of you may be more familiar with, the idea of upstreamism. And if you aren't familiar with that, you can Google it and read the little story that goes with it. But, most of us in primary care are working with an individual, and we know to think about that individual and maybe their family and maybe their community. But what is it that's causing a certain community to not have green space? Or why is it that in some communities there isn't access to, fresh fruits and vegetables? And those social structures, those laws, policies, and institutions are equally active in causing the uncontrolled diabetes as the individual person's dietary choices. So when we think about that list of social determinants, what I'd like to do is broaden your thinking, your clinical differential, to include the structural forces that are causing the social determinants. And so for patients like ours, that includes things like trade policy, even just rhetoric, let alone actual immigration policy itself, structural racism in healthcare, and frankly, structural racism in many aspects of our society. And there's also something that we call in our sort of field agricultural exceptionalism in labor policy, which is that there are a lot of, and actually it's quite active right now in the state as labor laws are being debated, where folks who work in agriculture are not subject to the same labor protections. They can't benefit from, nor are they affected by the same labor protections that most everyone else has access to. And then, of course, our healthcare system, which we spend a lot of time talking about. But it's the idea that all of these very large forces are actually affecting our individual patients. And so that brings us to another concept within this framework called structural violence. This concept was popularized by Paul Farmer, who you may be familiar with, but was actually coined many years prior to him by another physician anthropologist. But structural violence is an important concept because it takes that idea of social structures and it links them to the individual. So the arrangements that put people in harm's way are these large structures that are embedded in politics and economics of our social world, but they're violent because they're causing injury to individual people. So structural violence. So as we come back to our patient, one of the ways that the Structural Competency Working Group has thought to explain and to teach this idea is something that they call an arrow diagram. And just like we have different frameworks when we're like working up chest pain and or we're teaching our learners how to structure their thoughts about what could be causing chest pain, this is a way of structuring thinking around what are the social structures that are affecting my individual patient. And so typically these words that you see here are kind of what we know in our standard medical care: non-adherent patient, uncontrolled illness, and she's presenting to clinic today with her half-empty bottles labeled in English, peeling off. And we go through, the typical things that we might do. But when we're thinking structurally, we think much more broadly because we have to, because we're thinking about these large policy and social issues. And so that requires us to have a much broader history of the patient, which of course, as an individual, we're not maybe going to get in one office visit. But as we become familiar with a particular community, or we partner with people like community health workers, we can gather more of this information to give us more perspective. So this is the story of my particular patient who immigrated here after the natural disasters, now more than almost 15 years ago in Haiti. She moved to a town in Florida called Fort Pierce. She's here on temporary protection status, which again is a very relevant immigration issue right now for many of our patients from Haiti. Finds employment in sort of a temporary position, moving every 2 to 3 months across the East Coast. You can imagine living in temporary housing. She has very limited food choices, not to mention the way that poverty and other things affect access to food. Her care is fragmented through mobility and also the lack of insurance. So she's treated in acute care settings, sometimes with samples. Bottles are labeled in a language she doesn't read, et cetera, et cetera. So from this story, we then overlay the social structures that are driving this path for her. And those are here in red. Such that we can think of the different structures leading to this moment here where she appears as a non-adherent patient. These are all relevant to why her diabetes and blood pressure are uncontrolled at this time. Now, a lot of, and so this slide, this would be another term another way to describe what we're doing here, which is the idea of a structural differential. So it's a way to delineate these social, economic, political factors that are influencing the patient's health. And then it begins to allow you to think about what might be modifiable. Now, all of this is usually very overwhelming, especially to folks who are accustomed to working with an individual patient. Like, how can I possibly be thinking about labor policy when I just want to get through my 20 minutes with this person and make a difference somehow? And so that's true. And typically when we start to teach these concepts with the structural, as a seminar with the structural competency working group, we have 4 hours and not 30 minutes. So if you're feeling a little overwhelmed right now, that would be appropriate. But one thing that I often say to people, which I think is really, really important and relevant to all of us in medicine, is that our job as specifically as physicians, but as anyone in healthcare, part of our job is to explain illness to the patient, to their family members, to the people around us, to the school board, whoever. And so I feel as though I think it's true that being able to name social structures as direct causes of illness at an individual level and also of health disparities is critical. And when we don't name those things specifically, like not just saying that someone is food insecure, but talking about what it is that's leading to a disparate access to basic healthy food for people, if we're not discussing that and naming it, then we're not going to be able to gather the team or bring that cause to light to folks who are in a position to address it. So we don't have to fix everything, but we do have a responsibility to accurately name what it is that's driving illness for both our individual patients and for communities. Another way to use this concept is to think about patients as being structurally vulnerable rather than thinking about them as non-adherent. And that is kind of just a shift maybe of words, but it also, I think, creates a shift, I was going to say energetically, but a shift for us as people, because if we really don't think about large social structures when we're faced with a patient, like the example here, and we're left with either them or me, either I'm not doing a good job encouraging them to change their behavior, or they're not doing a good job of taking care of themselves. And it creates this sort of tension and this stuckness in our daily work that I think over time can cause harm to us as providers and certainly to our patients as well. So even though we can't change everything about these large social structures in an office visit, if we're able to hold them in mind as part of a driver of the situation, I think it makes a big difference in the work of providing care. And then thirdly, it provides us with opportunities and a framework with which to collaborate with folks maybe outside of, well, definitely outside of healthcare, to conceive of different ways of intervening. I don't have a lot of time to move forward with this, but with this particular case, what we do when we teach more about this in detail is we demonstrate sort of different levels of intervention. Structural interventions is the way that the term that we use. And those are at the level of the intrapersonal, kind of like what I was just talking about the ways in which we work with our patients and how these ideas can affect the way that we, even those individual interactions, to changes at our clinic and hospital level, community. This concept can inform research questions, especially for folks looking at disparities. And then obviously there's a lot of policy and advocacy and organizing work that is relevant and are ways that we can intervene. Okay, so for the formal side of it, this is a concept that's been discussed in the literature. It was brought forth originally by two psychiatrists, Jonathan Metzl and Helena Hansen. And I have links to all of the, to a lot more resources, both in the handout that we'll send to you and also at the end of the slides. But they have these 5 competencies, as we're accustomed to in medical education, that make up this larger idea of structural competency. And it's really meant to be a shift from cultural competency, which was popularized, in the 80s and the 90s. There's so much more that could be said about that, but to summarize, what I'm hoping with this very little snippet was to expand a little bit in terms of how you think about illness and disparities, and to sort of plant some seeds for how you might bring that awareness, especially into situations, patient encounters, et cetera, that feel particularly intractable, or frustrating, or tragic even sometimes. If this has piqued your interest, it just so happens that the working group that I'm a part of is leading a completely free seminar next weekend that you can register for. I think it's 3 hours. Yeah, so obviously much more detail than 30 minutes. And I basically did it in a half an hour. I have 2 slides with references, and they're also in a document that I can upload to the chat. And I'm going to stop sharing my screen. Oh, no, I'm going to show you the slide for your CME. That's what I'm going to do. Maybe we can put that in the chat as well. Okay.
Thank you, Cheryl. I'll definitely put that in the chat for anybody that needs it.
Okay.
And folks, I'd love to open the floor for questions.
Oh, Alyssa. So there's a comment in a couple of comments in the chat from Alyssa Dunn, who works up at our Four Seasons practice in Fairfield. And I believe what she's talking about is a patient that she's co-managing, but is a farm worker patient. And when she says the patient had great education from Lourdes, that's one of our community health workers at Maine Mobile Health. Really has made a difference for sure. What questions do people have now that I can sort of see some of you? I'm curious if this is new news or really not that different from things you've learned before. Quiet. Okay.
I'd be curious. I know we have a lot of educators in the room today. I'd be curious to hear, are folks already integrating this into their conversations with learners? And if so, what's been successful?
I feel like you could also answer that question for the group, Cheryl, about how you have been intentional over the years in trying to integrate this for our learners at Maine Dartmouth.
Yeah, I see residents. I see all kinds of people who have heard this talk before. So partly it's just a bit of a broken record, but I think that idea of a structural differential is one that we put together in order to kind of link into the ways that we already think. Like we already think about when things are a little bit confusing. Why is this patient short of breath? We're trained to work through organ systems and et cetera. And so we have done a couple different times when we've been doing a case presentation anyway. I remember then after we work through the medicine of it, then also sort of generating the structural differential, because I think it's helpful, if nothing else, especially for learners who are right in the thick of so much that is intractable and overwhelming, I think it's really helpful to be able to have a shared vocabulary and language to put to that. Like, yes, we are only able to do so much, especially in an inpatient setting, but even in the outpatient setting, and that sort of circles back to that little autobiographical piece that I had towards the beginning. Like, we're doing the best that we can. And even the system in a lot of places is like the literal healthcare system or the clinic, or at that level, we're putting a lot of resources to this. And why are people still getting harmed? And I think for those of us who are accustomed to fixing things, it's really hard to then name stuff that we can't just also fix. But there is a lot of power in naming things, and having an awareness of it, and bringing that awareness into our own understanding, but then also that of those around us. So I think, we definitely have formal presentations about this at different points, at the beginning of intern year, at the end of intern year, and I try to integrate it into a lot of the chronic disease education that we do. But it also just comes up organically as we bump into things that are challenging. One of my colleagues that was a co-author of the article that we wrote about the structural differential actually routinely incorporates it into their hospital rounds. And there's groups of folks, I think out of Montefiore, or I think, that do like social medicine rounds sometimes. And I think there's lots of ways you can play with social medicine rounds. You can do poetry and like get into, the affective side of things. But this is another framework that one could introduce in that type of a setting, that I think is a helpful break. And I guess the last thing that I would say that is not part of the formal curriculum from the working group in California, but for me, I've been teaching this in different formats for probably, I don't know, 8 or 9 years now. And I think what's missing still is how we're holding all of this as individuals, like within our bodies, and kind of linking these concepts to sort of that embodied sense of frustration, and understanding that, sort of paying attention to the ways that as we move through, practicing medicine in this day and age, that we're a lot of this sort of burnout and moral injury that we're talking about has embodied consequences for all of us. And so we can start to pay attention, if we pay attention more to how we're physically feeling as we're moving through this work, that's like a flag to us that there's more going on in this encounter than we're able to adjust with our like Januvia and our whatever. And that it's a time to pause, both for our bodies, but also, to understand things in a more accurate context, actually. So that's a long answer, but no one had other questions. So,
well, I'll put a last call out for any last questions folks might have. Oh, we have a hand up.
Julia has a
Christina.
question. Dr.
Yeah,
McDonald.
hey. Cheryl,
Hi.
thank you so much for that. This is Julia McDonald from Augusta, Maine, Maine General. I'm here with the residents in this room. That was an awesome presentation. And I guess I have partly a question and partially maybe a statement, because I've been sitting on this question as we've been talking. The question is, so what do you then do knowing all of this and holding all of this in our mind and interpersonally? What do we then do with the A1C of 13.6 or whatever? Because we have her for 2 weeks and then she goes away again, and we can't fix that. So I feel like one of the things that we constantly run into here in the hospital is this wide, broad awareness of all of the societal burdens that our patients are facing when they come in and have their foot amputated because of diabetes or whatever. And we're lucky that we have social workers and case managers, and we try and work this out, and we try and get Zerbach to go visit them with Meals on Wheels and help with loneliness and diet. And like, we try and fill in all of those gaps. but it feels like for me, the bridge is still knowing all of this and working to fix all of those other issues while still being graded on that quality measure of the A1C level. So that's one thing. And then before I turn off the mic, the second thing that I want to say is I really appreciate the zooming in from personal to societal, because this is exactly what fuels my advocacy on a state, national, and international level. These patient stories and holding them in the context of this world, and then being able to go talk to my legislators or to, file something for the Supreme Court about how larger policies are affecting people on a very granular level. So I want to encourage all of us, if we're feeling overwhelmed and angry and frustrated, to fuel that into another avenue, because there are things that we can do. We have a lot of power. Thank you.
Thank you for that comment, Julia. That obviously is not a quick answer, but when we published this series of articles about all these different social medicine concepts a few years ago, they asked Paul Farmer to come talk because everyone wants to hear him talk, and he sort of addressed that. And so I'd like to just repeat what he said, which is that it's important for someone to be talking to the housing authority in Boston about the mold, but somebody also needs to be in the ER for the little kid that needs the fourth neb. And so adding this information and this awareness to our understanding of things does not devalue the work at the other end of the stream. And it continues to be important. But I think, so, and also I really think that, we all have different roles and we all move through a lot in our education, so that, I at one point knew some things about, well, a lot of things that I don't use anymore. But if I had to explain to a patient what happens when they get their hip replaced, I have a place to start from there, but I'm not worried about the fact that I can't replace their hip. Somebody else is going to do that. And so I think the idea, and especially the idea behind this working group as they work nationally, is, we've done this work, we've done this education with community health workers, all the people, to try to shift the language, because it really is going to require collaboration. Even when I think about farm workers and collaboration at between labor and immigration and education, and it's well beyond medicine, and kind of coming to the idea that health, it can't just sit over here in the hospitals. And I think people intellectually know that, some people, but we all have our own role to play. And I think maybe because we're in family medicine, we're especially feeling like we got to do everything. But I do think that it's not meant to devalue the acute care at all. And it's also not meant to devalue, I think it's important that we don't devalue our role as narrators, amplifiers, both of patient stories, as you say, but also the why. So, yeah, thank you so much.
Well, we are coming up. I'll put my camera back on. We're coming up on time. I will give, is there anyone else have a last quick question before we put a cap on it? Well, thank you, Dr. Seymour, for that fantastic presentation. I also want to say thank you to Department of Health and Human Services at the state of Maine for the grant dollars that support the Merge Collaborative and the Building Maine Network, who are the co-producers of our Grand Rounds series. Before we all sign off, I'd love to give a sort of a teaser to what will happen next month. On June 14th, our next presenter is Dr. Eva Quirion. She's a nurse practitioner and holds a PhD from the University of Maine, and she's a lecturer in nursing. She'll be presenting Integrating Addiction Care into Healthcare Provider Education. So another pressing need across the state of Maine for us all to learn a little bit more about. So with that, thank you to everybody for attending today. I will end the recording and this will all be posted online. And I'll also make sure to send out to everyone who attended today the pamphlet that Dr. Seymour referenced. She has just a little PDF that goes with what she talked about, which is a great resource. You'll have that available for you as well. Thank you, everybody. Have a great afternoon.